So let's try to get started. We're a minute or two late already. That's not too bad given things. As I said, I'm so glad this is a 5-day meeting because we have so much to talk about. There's been this gradually sort of opening up of CCP in a whole variety of ways, from understanding the individual needs of patients to a program to address them, to from medical to social and broader context. And you'll see that progression in some ways throughout the day. But as we all know, so much of what matters for patients' health outcomes is not just what medical care is, but really the broader social context. And this session will highlight some of that and talk a lot about the programmatic developments that have really been important with this. So our moderator for this will be Katya Smythe, who I'm thrilled to have join us today. She's going to introduce herself, and let me turn things over to you. And
thank you, David. And it's great to be in this room. And I've had such great conversations. I know so many of us have. So thanks again for pulling us together and the sort of as a milestone, but not a summation of the work that everybody is doing so far. So I'm Katya Smith. I'm the founder and CEO of the Full Frame Initiative. And what I will say is that I think I am here as the non-medical provocateur. We can talk more about what that means. But I come with deep appreciation for and some partnership with some of you over the years, and a feeling that there's work that is happening in this room that doesn't show up in Epic, that is actually where the heart is, and our whole bodies are what you treat. We are all patients. We are treated as our whole bodies, and yet so much of the system that you all are operating in only uses the neck up to figure out what's going on. And so I think that in some sense, there's a whole body approach on both ends that CCP is intrinsically rooted in. Before I turn it over for some amazing presentations, everybody I know has a pen and everybody I know has paper. And so everybody can do what I'm about to ask you to do. No excuses. I'd like for everybody, and you are not going to have to share. There's not going to be sharing out of this, so you can be honest. Just to complete this sentence, I am the 5 things that come to your head. I'm a deacon. I'm a runner. I'm a mom. I'm a Celtics fan. I'm a whatever it is. Just write those down, put them to the side. We'll come back. And if you have trouble thinking of 5, we need to talk about work-life balance, which is a whole other conversation. It is a real honor to be here with Emily and Nicole and Elise, who are going to, I think, share with us 3 perspectives that are resonant and also different. And I think that's one of the really important things for us all to hold, is to not try to always find the lowest common denominator in this work, but to hold the spaces of complexity where they're actually, to figure out where in this work there is the value in the differences of opinion and where we actually all have to be on the same page. And so with that, I'm going to hand it over to Emily, who has her own microphone.
Yes. All right. Okay, so I'm Emily Parrish. I have worked with the Comprehensive Care Program for many years at this point. My background's in public policy. Today, I'm going to be talking about the Comprehensive Care Community and Culture Program, or C4P, and specifically focusing on our experiences in implementing the different components of the model and some considerations for sites who may be interested in doing the same. So Many folks have seen this information, so I'm going to breeze through some of it, but for those who haven't, the impetus for the C4P work came out of the original CMMI study of the CCP model, and we saw there were a portion of patients, about 30%, who never engaged with the program, didn't end up, despite expressing interest, coming to clinic. And we talked with many of those patients and learned about the range of social barriers that played a role in making it possible to come to clinic. And so with an opportunity for funding from the Robert Wood Johnson Foundation, we set up an expanded model, the C4P model, that adds elements to the CCP inpatient outpatient care continuity model of systematic screening for unmet social needs, access to a community health worker where those needs are automatically sent to that individual who's embedded in a team of social workers. You'll hear more from Nicole about how that process of triaging works, and then access to community-based arts and social programming, with the idea of this conceptual model of patients who are maybe less activated in their care, who we have not engaged in the program. Could these added elements do a better job of bringing them into the program and increasing the likelihood that they receive access of care from a comprehensive care physician and the benefits that come along with a longitudinal relationship? The program, of course, now is funded the research by PCORI, and we're studying it in a 3-arm randomized trial. We're about halfway through our recruitment goals right now. This is to just give a sense of the distribution of unmet social needs in the pilot. So about 60% of patients were experiencing very few unmet needs. We do see a concentration of unmet social needs in about 41% of patients, and actually about a quarter of patients are accounting for 5 or more unmet needs that they're experiencing at the same time. So we wanted to get a better sense of not just what was the distribution of needs, because it was so wide, but how do the needs tend to co-occur in these different social domains? So these are the 17, actually 16, there's a 17th domain, spiritual related needs that isn't listed here, that we are screening for quarterly. And these are the ways that the needs are co-occurring. So they fall into these 5 different classes. All the way on the right are the folks who are experiencing very few unmet needs. But all the way on the left are folks who are experiencing many unmet basic needs. They represent different structural related needs: food, housing, transportation, legal needs, personal safety, et cetera. The next group of patients are those who are experiencing needs around healthy eating, physical activities, engaging in social activities. There's another distinct group of patients who are experiencing needs around finances and health insurance. And then a very small group, and we've repeated this analysis a couple of times, and these groups are persistent, though this last group I think may have fallen out in recent versions, but are folks who have child-related needs. So as we learned more about those clusters of needs, we actually did a series of qualitative interviews with patients who fell into those groupings and started to build out different programming with renewed funding from the Robert Wood Johnson Foundation to address each of those clusters of needs. So for that first group, where there are many unmet basic needs, we designed a social service alignment learning collaborative. Elise is a longstanding participant and co-creator of that initiative. We've been meeting now, having case-based discussions around barriers, particularly with the population of residents who are experiencing 10 or more unmet needs simultaneously, and the untenable nature of navigating that amount of systems and the structural barriers that are at play. We've been meeting for about 5 years at this point. We have built out a community garden program where patients have access to fresh produce, not far, probably a 10-minute walk from here, on some vacant property. We do cooking demonstrations and different types of arts and social programming in that space. For the health insurance financial related needs, we have a program that's social work driven called Living Well Financially. It runs the gamut of sort of education-based supports to behavioral health supports in navigating financial challenges. And if the child-related needs group grows over time, we'll think about building out more targeted programming there. This is just to give a sense of organizations involved in the Social Service Alignment Learning Collaborative over time. David alluded to some of this, but some of the preliminary results from the C4P pilot, the RWJ funded pilot, The most sort of standout result is around C4P patients who are experiencing 30% lower hospitalization rates than compared to patients in the standard care arm. Also, we saw that reductions in hospitalizations were higher in patients who are predicted to be less active or engaged in care. And so think the added elements of C4P may be doing what we are hoping that they will to better engage patients in their care. So in addition to those couple of conclusions, we also see that C4P operations are iteratively improving and that we are successfully engaging patients, that we continue to look for ways to keep improving. We will want to, as we continue to enroll patients into this larger RCT, also look at claims data and see how hospital utilization is validated. And we also see comparable benefits of C4P versus CCP in patients with high or low baseline hospitalizations. So I want to spend the rest of the time talking about different considerations that sites might have as they think about either adding C4P components to an existing CCP model or starting a model from scratch. So from each of those three component areas. So first is screening for unmet social needs. So this is an area that it may be easiest to add the screening to the work that is already being done, especially if there is some type of care continuity model in place. Adding on a screener to, at some regularity, have a sense of what needs are in the patient population, also to better formulate the social service provider setup and potentially community-based programming to address those needs. Many institutions have SDOH screeners and efforts in place, so getting a better sense of what those look like. Sometimes they're very narrow for certain purposes. Are there opportunities to expand those? We've found that it's very helpful to have an expansive set of questions that we're asking so we can get a better sense of the whole person and needs. Thinking about who and how many people to screen, you may want to think about screening folks who have been readmitted or have another criteria like a prior admission. Thinking about how to screen, who's going to do it, who's sort of the workforce, is it built out as part of research or part of a learning healthcare system, other institutional efforts. When thinking about building the social service provider component, I know a point earlier in the discussion was don't start a program without a social worker. And I think from our experience, we wholeheartedly support that. And in thinking about what that team looks like so that we're supporting that individual and hopefully individuals in growth and in building pathways for growth to avoid turnover and burnout. Understanding what are the existing social service resources that exist, value-based care models that are in place. Are there opportunities to integrate with those or grow from them rather than reinventing the wheel? Sometimes those models are set up in such a way that it's difficult to do so with inpatient, outpatient continuity. It depends on the setting, but worth understanding. This is also ideal for social service team members to be co-located if possible with the rest of the care team, both to be building relationships and communication pathways between providers, the CCP physicians, social workers, and the rest of the care team. Also to be better supporting and facilitating relationships between the social service team and patients over time. Another consideration is how are patients directed to the social service team members? Is there a specific population that's being targeted or addressed? Is a certain headcount trying to be achieved and so on? Building in mechanisms to track data about engagement. So that's something that we continue to work on, and I think would be interested to hear from others and how they have set up mechanisms to do this, but having a sense of different team members. Are there certain social service, social need domains that are better worked on or where we have greater challenges? And then, as I mentioned, supporting pathways for growth. And then just a couple of notes about the community-based social programming. So one, we're learning a lot about patient needs, and this is also an opportunity, I think, to be in conversation with participants in the program about what are their passions, what are different assets that we all have and bring to the work and to life. And so learning about those, collaborating with participants in the program to build out events and activities that reflect not just maybe educational opportunities around addressing some of the social needs, but also highlight and celebrate the talents and passions of the participants as well. And so we've had folks who have musical backgrounds or backgrounds in art who help to facilitate those events. And we found that really engaging. This is also a low cost way compared to some alternatives to engage patients and simultaneously address their needs. So finally, I want to highlight a project that's been sort of an offshoot of the C4P work and also a response to the structural barriers that have further created health inequality. And so in Chicago with the U Chicago group and the U Chicago Health Lab, we had a sense of needs of housing and financial related needs of patients in the C4P program. We also wanted to focus on this challenge where there are many older adults who have low or fixed incomes and are struggling to afford basic needs. Housing is often the largest portion of those needs. In Chicago, especially on the south and west sides, we have a large number of multi-unit homes or apartments versus studios and one bedrooms. And so there's an opportunity here potentially to pair older adults who are interested in a roommate to one, get the benefits of substantial savings and costs of housing, but also the benefits that come along with companionship and social support. So we're in really early stages of this, interviewing patients to learn more about how this would work successfully and what would need to be in place, and then seeking funding for a pilot to try this out. Thank you.
Hi, everyone. My name is Nicole Gear. I'm a clinical social worker. I've worked in the comprehensive care program with David and Emily and so many people in this room for the last 9 years. Today, I'm going to talk about how to get married and have 2 children if you start a complex care program, which is not what I'm going to talk about, but that did occur while I have been working in the program. And I think very much speaks to some of my emphasis and work, and what I've really enjoyed thinking about is how to deeply form relationships. And in the complexity of the landscape we're looking in, how do we keep teams together, keep our patients or the people behind that label of patients, the focus of our work. So I'm very interested in like the origin of words, and we talked a lot about buzzwords today. So I looked up defragmented, and it actually comes from the computing world, which I have very little knowledge of. But it means to optimize a very cluttered hard drive. And so I started thinking about the spaces that we're all working in and all the complexity there, the mapping that we have to do, the communication that we have to do. And it is a pretty cluttered space. And so how do we think about optimizing our workflows as teams and for the people that we're serving? You've seen this slide a few times today. But just like notching the social work team and the social service team within this broad ecosystem of unmet needs, a healthcare system that's not particularly well designed for folks who have frequent hospitalizations and interactions with it. And then the multiple different ways that these needs could present just presents a very daunting task to any clinical team or any model that's seeking to address this. This busy drive needs, defragmenting, but my colleague Nancy, who manages our clinical team, kind of put together our eco map right now. Here's how our social service team, which has grown, and you can see all these different roles and concentric circles. And, there's a lot here that we do, and we run the risk of really siloing off into the community health worker does transportation, and I, the social worker, do behavioral health interventions. And so we've really been intentional in trying to think about what are some overarching stances and ways that we could think about integrating our perspectives, our differing backgrounds, the fact that we're all progressing in our career at different stages, so that we don't just have that linear kind of rigid model. So this is one attempt at displaying these moving pieces. And I would say we're still tinkering with our visuals on all the things we do. So several years back, a team of us started thinking deeply about like, why are we doing the work we're doing? Why are we seeing what we're seeing? What are we feeling? What's coming up for us as we discuss, the patients every day and some of our attempts to navigate this complicated system. I won't go through all of these. I'll let folks read through it, but here's, some of the things we landed on and some of the things that I think we really wanted to build into our team, our communication, our meetings. So we go back to this statement. I think I would love to start every day with it because it is a nice place to ground our work. And from that, kind of what we did earlier in a session, we started with a theory of change model. And so again, another pretty busy moving piece of the slide, but what strategies do we as a complex care social service team employ? What factors are influencing our work? We found it really important to start with a set of assumptions. And, the very research-minded folks in here know that assumptions can't be proven, right? These are just, we're going to stipulate to these because we believe it'll help us do our work better. And so we ground these assumptions and we talk about these assumptions and why they help us navigate the complex social needs landscape. Looking at community barriers, the assets of your community, I think many folks already talked about today, the populations we're all working with are going to have different categories of these. So I am a behaviorally trained therapist. And so one of the lenses that I've brought to my social work and social needs work that's always been in medical settings has been like a therapy behavioral modality. And so as I was trained in that, I started seeing some things that I thought were really valuable to complex care and CCP. And one, some of you may be familiar with dialectical behavioral therapy. That could be a whole nother conference, but this is a modality which really has two, I think, key features that I found important for complex care programs. One is it's a principle-based treatment that really focuses on two themes. Change being how do we problem solve? How do we move people forward? How do we ask them to commit to do hard things and be uncomfortable? And acceptance, knowing that we also have to validate where they're coming from. There's a reason why they are manifesting the things that they're dealing with. There's probably structural, environmental, and all the other things that we know to exist that have caused these problems. And that really resonated with me for the folks that are coming into our clinic. They both need problem solving and someone to understand why their life looks the way that it does. And if we go at that at any one angle too hard, we're going to lose people. They're either going to feel invalidated and not come back, or they're going to say, what are you going to do to help me? So we have to be able to dribble with both hands. The other thing I'll pull out here is DBT as a therapy is one of the few that has an intentional focus on the therapist. So the therapists in this modality have to meet every week. They have to reflect on the work and how it's impacting them. They are tasked with the same accountability to change, develop skills, grow, do more, become better, so really this focus on we're part of the work too. Our histories, our challenges are going to show up in the room with the people that we're working with. And so that really resonated with me in complex care models. We're having long-term relationships with people. Our stuff is in the room, whether we're going to acknowledge it or not. Excuse me. So a little bit of this balancing these two principles like problem solving and validation, and then what are the vehicles by which we're doing this? So change and acceptance, and a lot more I could go into there, but I wanted to kind of give you a look at how we started to translate this a little bit in our team. So on the left, this all probably looks familiar to all of us, some of the aspects of a traditional medical team. As we started to infuse some of these DBT principles into our, into CCP, you know, we started thinking about, we're a community of clinicians treating this group of patients. And I think the model's already set up intentionally like this. You know, if Grace is on service, she's seeing Joyce's patients on the weekend, or she's seeing Ram's patients. So we really think of ourselves as a group of patients. We've moved from that's your patient. We're not perfect at this, not my patient. But we really, I think, do try and think of ourselves as a team, and we do panel people. They do have a primary care physician. They do have an assigned social worker. We want to be effective. And I think when we're talking about our patients, we really kind of own that this is all of our responsibility. You'll see in a few other slides, we intentionally invite vulnerability into the room. We focus on our clinical team. We ask them to commit to things, to operate from a set of assumptions. And we're certainly working back and forth with how do we accept this person where they're at and invite them to change at the same time. And that is not an easy line to straddle. Maybe like, how does this look? So I like this slide, like in many teams I've been on, like it's the patient that's the focus. They called the answering service too many times over the weekend. How do we problem solve their behavior so that we all feel more comfortable? Another way to think about this is like, I feel frustrated. I'm owning what's coming up for me. I need some resources, some support, maybe some, you know, navigation on maybe yes to problem solve with the patient, but also some of my own skills could be built up. So a couple of examples there. These are a set of commitments, and this comes out of the DBT world. That treatment team of therapists, they all get together weekly. They have a set of commitments that they operate from. And we felt it important in our social service team and even our broader team, because we've invited our physicians into many of these meetings, to take a look at commitments. You know, I'll submit to you, human relationships revolve around commitments. The highest form of human behavior is our ability to make a commitment and be accountable to one another. And we're asking our patients to do a lot of things that are hard to do. Show up, wait, call again, come back, get another test, things that would be uncomfortable for us. And so I firmly believe to have longevity in a complex care program, we need to get good at making commitments. We need to get good at being accountable to one another. And so this has been a framework that our team talks about every week at the start of every meeting. We bring patient cases or personal stuff to the room where appropriate. And we talk about, like, it was hard to set a limit with that person, and this is what came up for me. A little more of the nuts and bolts of like, how do we get referrals? You know, we've really from the beginning operated from this, can I do this thing? Do I know how to do this need? Do I know how to, you know, search for transportation or find a food resource? Do I need to consult with another team member? Or do I need to refer to someone entirely different on the team because they have a different skill set? It's broad, it's flexible, it allows for the growth of that particular clinician. What I knew 5 years ago is very different than what I know now. So what I would consult someone on is something that I can do now. And that's been the case for many of our social service team members. It allows for that growth and longevity in the program, and to kind of, you're not always the person doing transportation because you are this title. And that's worked well in our evolving team. We've also developed a language to triage cases, and I've heard many of you guys talk about how do you elevate voices in the room, or how are, I'm not picking on physicians because I love them, but how are the physicians not the only people speaking in a room? So this is a triage system that we developed, also comes out of the DBT landscape. It asks you as the clinician, if you're bringing a case to consult on, to identify, you know, I'm feeling like really distressed. This is a level 1 for me. I'm like not able to continue my work because I'm thinking about what to do next. You're ranking where you're kind of at on this. And then you're also talking about the needs of the patient or the case. In this meeting, we go to the highest ranked need, and that could be the clinician. So it could be a patient need that's a 2, but if Nancy's there and she's saying, I'm at a 1, like I am really struggling this morning, we're going to her case first. And so it ensures like we're not leaving the last case, most urgent case to the last thing that we're squeezing in before we're running to another meeting. I think it also helps team members know that like you're just an important part of the work as patient needs. A few examples here. I won't go through all these, but here's some of the things that a team member might bring to the meeting, mostly revolving around, I don't know what to do, I don't know how to do it, or I don't want to do it, I don't feel motivated to do it. And those are all reasons we can consult and work and build skills in team. And then, of course, various patient needs that could fall at any level at any given time, also embedded in their medical care. So like a housing need of someone coming into the emergency room looks a lot different than a housing need of someone who's been living in this apartment for 20 years and has like 3 months to move. So we're always kind of placing the needs in the context, in the timing, the urgency, and also the intersection with their medical needs. And then lastly, accountability being a part of commitment, we have intentional process reviews. So we end our meetings kind of going back over, did we honor our commitments to each other? Did we make judgmental comments about our institution, our program, our consultants, our patient, like how do we continue to look at areas to improve? And these change and evolve, and we've had different commitments at different times. But it's been a key part of our work to kind of practice the same things we've been asking our patients to do. So thank you.
I think they can do this. There we go. Yeah. So as Katya mentioned, some different perspectives to be shared on this panel. My name is Elise Citrini. I'm actually not a medical provider, no medical training. I'm a lawyer. I work at Loyola College of Law as I teach in the clinic. The way that I got involved in is, as Emily mentioned, is working with the Social Service Learning Alignment Collaborative. And through my work at Legal Aid Chicago, where I was providing civil legal services for people living in poverty in Cook County. So we'll talk about using legal tools to address medical challenges. So again, I'm going to define what is a medical legal partnership. Maybe some of you have heard of this concept before. I'm seeing some nodding heads, which is really, encouraging to me. And then kind of identifying, I think about lawyers a lot as cultural translators. Like we're doing a lot of translating for our clients, for, to the jury, to the judge, to, different administrative boards. And so now in this kind of medical legal partnership interdisciplinary world, I work a lot as a translator between medical providers and patients, medical providers and lawyers, medical providers and administrative agencies. I grew up bilingual, so translation, cultural translation comes very naturally to me. It was something that was just part of, kind of my genetic DNA, my DNA growing up. So we'll be talking about using, mnemonic devices to help translate these concepts. And then finally, we'll be talking about thinking, how can we generate, talking about implementation and change, how can we generate ideas for reproducing these types of interdisciplinary partnerships in different settings and different scales. So first up, I saw some nodding heads, so I'm glad this isn't brand new information to a lot of you, but a medical legal partnership is a healthcare delivery model that really embeds legal expertise within the healthcare team in order to identify, treat, and prevent health harming legal needs for patients, communities, and for population health. Where legal professionals become part of a healthcare solution, partnering with this team to respond to these social determinants of health. So where I work currently is a law school in Loyola. We have a medical partner with our hospital team. And so there's a lot of education. There's a lot of screening information about how do you define a like a health challenge and through legal terms. There are potential legal solutions for a lot of the social determinant issues that your patients face. And one of the great things about being part of the learning collaborative is that we can help each other, again, like that cultural translation, help define and understand, oh, well, this is an income challenge that my client's facing, but there's actually a potential legal mechanism to address that income challenge. And the way that we can do that is the mnemonic device. So like I said, doctors love learning with mnemonic devices, so I've heard. And so the National Center for Medical Legal Partnership created this mnemonic device to help translate what are some common social determinants of health issues, and so we can understand how legal services can get involved and actually address those social determinants of health. So we use this mnemonic device called iHelp, and it divides up kind of legal challenges and social determinant challenges. And the primary one that in my role at Legal Aid Chicago, working with several medical legal partnerships, where we really were able to focus was on that I section, that income, which income and insurance is another way to identify that I. Because number one, that was where when we did our focus group to design, like, what was this medical legal partnership going to look like? A lot of the barriers for patients to access care was income barrier or was ability to be insured. And so many of our clients who are living in poverty are, they either are eligible for Medicaid or potentially eligible for Medicaid. And if they were having barriers with that access, health systems have phenomenal, very advanced and very sophisticated ways of making sure their patients are getting the health insurance, Medicaid that they're entitled to. However, there comes a time when there might be a challenge that would require like a legal intervention. So an appeal, a deadline that was passed, something that creates a barrier where the patient is not going to be able to have access to that insurance without a legal intervention. And so that was a really productive place for our medical legal partnerships to connect. And so training and screening training those folks who are doing that type of screening, who are doing that type of assessment and analysis was really helpful to get us our referral clients so that we could make sure that we could increase their income and insurance. The rest of the mnemonic device is really useful. Housing utilities, as we saw, housing can be a huge barrier, huge challenge if patients don't have access to safe, stable housing. And there are, especially in Chicago, we have a lot of really great tenant-friendly laws that can be utilized to improve someone's housing conditions, that can get them more time to move out. Those housing challenges, folks might not realize have a legal solution. This is the classic MLP example of a patient who keeps coming in because they have chronic asthma. So they have asthma, the patient gets treated, maybe they miss school, maybe they have, so they're seen in the ER, they're seen by their primary. But really the underlying root cause is that the house that they're living in has mold, and there is no money for remediation for that mold situation. Well, there is actually a legal mechanism for a solution there. That patient or that patient's family might have legal recourse to withhold rent or do self-help, but you want to have an attorney involved. You don't want to just give that advice and say, well, why don't you just withhold your rent? No, you want to have, you don't want to do that. You want to have an attorney involved so that they can do that, do that the right way. And then you can remediate the root cause of the asthma exacerbations, which is the mold infestation in the home. All right, so I'm not going to read through the rest of iHelp, but it's really useful. All right, so just a little bit about how the model works. So a provider is, typically trained in identifying health harming legal needs by one of our team members. So they identify the health harming legal need and they make a referral to an MLP attorney. The MLP attorney provides this legal analysis and assistance. They say, okay, yes, this is a legal challenge, that there is a legal solution and I can provide this assistance and this service. Then, they do so, and then they close the loop with that provider. So they let the provider know, hey, this was the challenge that you sent. This is the actual legal remedy that was available. And this is the outcome. And then finally, we do a lot of data collection and analysis for seeing if there are mechanisms for any upstream advocacy. So let's say this is like the fifth of the same type of public benefits case that's coming out from the same public benefits office that we've been seeing. It's like, well, what's going on? What's going on here? Is there some type of more systemic legal advocacy that is possible? And through that back and forth and through that information sharing with our providers, we can really try to upstream those interventions. And find, again, like more systemic responses to these challenges. So kind of, I call this MLP Light because through the Social Services Alignment Learning Collaborative model, we were able to get a lot of the same benefits in terms of like relationship building, in terms of like facilitated learning through sharing in this group, in this organization, where I, as an attorney, like learned a lot about some different organizations and the services that were available to my clients outside of the MLP through the Learning Collaborative. So it really, again, it facilitated it was a facilitated learning environment with all folks from all these different sectors where we were able to learn a little bit about the work that they were doing, learn about the services that they were able to provide for our own clients that we were seeing, as well as through this case study model of going really deep into one specific example of how this particular situation, this person was going through these, had these social determinants of health challenges. And then kind of every participant would kind of chime in and say, oh, well, have you thought about this? Like, and me, because lawyers love to talk. I'm like, hey, have you thought about this as like, there's this like a potential legal solution here. There's a potential legal challenge here. Like, why don't we follow up afterwards? And why don't we have like a broader conversation afterwards? So again, it provided time for background and sharing and relationship building with those different organizations. Again, it provided an opportunity for issue spotting so that Nicole now knows, okay, when a patient comes to me with this type of challenge, I'm going to talk to a legal provider. I'm going to have a basis for referral that I might not have realized there was a potential legal solution here before. And again, it provided opportunities for consultation and advice without creating this more formalized, structured medical legal partnership. I love the formalized medical legal partnership because, we got to get paid for our work too. So I love that. But it can also serve as a proof of concept for actually trying to build in and embed one of a more robust medical legal partnership within a health system. So what do we need? What do we need to do that? We need, again, so it requires relationship building from both the medical provider side as well as the legal side. Providers have to really be able to see concretely, how is this going to benefit my patients? How is this going to alleviate my own burden? So like, I'm not having to think about, all of these other things. I have an expert in housing. I have an expert in, public benefits. I have an expert in domestic violence that I can, refer to right from my chart. Again, like the relationship building from the legal side. And then I don't know why I put this third because it should have been first, like the community partners, the community and the client voice is really the number one thing that an MLP requires. Like if your patient client doesn't trust. I mean, you talk about like kind of lack of trust that's building with the with medical services and with health systems. Nobody trusts lawyers. So we really need that community buy-in, that from the ground engagement with community to say, yes, this is a service that can really be here to support you, that can really be here to address these other needs that you might not even realize are legal needs. We need capacity in terms of both funding as well as expertise. And then we need an organizational buy-in, and that is included with the information sharing, data sharing, so that we can show that there is going to be a return on this investment. Those are all kind of things that are, when we're thinking about that change and implementation, these are the things that we've seen are really required to get this off the ground and make it be successful. Right, and then if there's any questions, I think we're open later, right?
So thank you all. That was tremendous. And where'd David go? I am glad that this is the first of 5 days because there's so much to explore here. For those of you who saw that we were passing notes, it wasn't about the teacher, it wasn't about who we like or who we're going to exclude on the playground. It was us doing what you all do every day, which is to improvise and figure out what makes sense as a next step based on what has occurred in the moment. So here's what we're going to do. My job is to offer some reflections and some questions, but what we're going to do is, instead of splitting up into 3 groups and doing a report out, in part because I think what's going to come out of this are 3 different doors into some of the same questions and challenges, we're going to have a discussion of the whole, not all talking at once, but working at some brevity, but passing a mic around and I would encourage us all again to have an emphasis on asking the question, making the comment that you're not so sure your colleagues are all on board with, so that we can really understand where there is that texture and richness in the room. So there are a couple of things I want to start out with. One is, and I want to start with systems, because you all are obviously operating in systems, but we live in all sorts of intersecting systems and ecosystems. And we heard the origin of the word defragmentation, which now I remember, I should probably get my hard drive, defragged. But everyone in this room is also, as patients and as providers, we are in a healthcare system that mirrors all the court system, the other systems in our country that are marbled with systemic racism, that with bad decisions and good decisions and history implemented well and not well, right? And that's sort of the legacy that we're all operating in. And particularly if you're on the front lines, you're not necessarily in a position to, see the impact of those systems, but everybody can feel powerless to change it. And so that's one of the things I want to reflect on, but also what I heard in the medical legal partnership is an endeavor at an end run around some of that. That not, to the extent that so many of the patients that we're talking about today are sort of individual manifestations of that shoddy policy and benign neglect and isms, the building connections and awareness across the bridging that MLP does isn't just about increasing. To me, what I was hearing is not just about improving results for patients, which of course is its primary purpose. But I guess is about increasing sort of a sense of mastery among physicians and practitioners who may also feel completely stymied by these issues in the absence of that. So it's not just about sort of the emotional support for that, but it is about saying, no, I can take this ball and run with it down the field. But I also heard about a roommate project that I would offer as an end run around so much of our housing policy that focuses on, unless you are sort of a family, you can't share space, right? And that reinforces poverty and reinforces housing poverty. So we're gonna, we're not gonna talk quite about systems. I'm improvising as we go a little bit. So I put that out there as one reflection. 30 plus years ago, when I was running an emergency homeless shelter, I remember Marie saying to me, "Why would I ever want housing? Every house I've lived in, I've gotten hurt." I think about David, a man I worked with who lived on the Boston Common, who wanted housing. But when he got housing, he didn't feel needed anymore. He was needed in his encampment. He had a purpose. He felt safer. He felt, right, he had connections. He had all these other things. And so I think also about when we are talking about what people need and what they want. We heard from Emily the importance of passions and identity, but let's not also forget the importance of just asking people what they have that's important to them. Because so much of resistance, or what we can label as resistance, is not someone saying, "I don't want what's on the other side of this." This came out of the patient discussion earlier. It's that I have so much to lose. And what I have heard in the discussion here that may not be reflected as much when we talk about the models and the outcomes is a deep understanding of that. And so my challenge also is when we're thinking about systems and system change and concretizing what the models are and what works, where are the places and spaces for actually building that in? That answers to the question, what do you have, not just what do you need? The third point that I want to just, again, throw out there before we open it up on the themes of systems and truly thinking about this, what do you have, so that we don't end up with people just as pathology wrapped in skin, is this issue of identity. So with all due respect, what I've heard from Emily and David and others, when you're talking about how effective these models are, reduce hospitalization, et cetera. I'm not arguing for higher rates of hospitalization. But Walter, I didn't hear from you leading with, "I was in the hospital less, and this is what," right? That what I heard, and when I talked to Gertie during the break, and when I think about my own experience being ill, which presumably many of us have had, there is a fundamental difference between whether we are seen as a person who has illness that is affecting us and whether we are seen as our illness. And you all, right? And so when we're thinking about the outcomes, differentiating process and outcomes, this differentiation between them, I think is something worth considering. Because often for a patient, one of the biggest outcomes can be, I actually was part of a medical system that for the first time saw me as a person, knew me as a musician, knew me as a professional, knew me as all of these other things. And maybe that's part of what matters, that we don't just bake into the process. But baking that in to, and I haven't done this work with medicine, but I've done this work in court systems and changing sort of the information they track. That's an act of systems change, which I recognize. But you all are, to the extent you're doing it on a practice level, there may be opportunities to build that into systems change. And then, Nicole, what I want to, I just felt like your work is tying together some of these themes of thinking about the systems that are operating within hospitals and how you shake that up and where you can do end runs around them, where you aren't just seeing patients as whole people, but you're actually holding care teams and the people within the care teams as whole people. And where there is a wrestling with this question of how do we not force people to give up what they have in pursuit of what they need? So with appreciation, for what everybody here has put out there and knowing that there's wisdom in the room, we have another slide that is here. I was hoping these themes would come through. An amazing job. These are some questions to think about. I think we're going to start by going one by one, and we're going to see if it completely collapses and people just want to talk about what you want to talk about in terms of these. Because this is as much your space, right? We're not going to seize all the control and choice from you. So I guess I'm curious in terms of reflecting on what you've heard, on a little bit of what I've shared. How are you all paying attention to reducing what in my work we call the trade-offs of change for folks? Is it worth it? That might be the trade-offs of change for patients. It also might be the trade-offs of change for institutions and providers. I'd like us to focus more on patients, but it's worth thinking about this. We pass some mic or should people yell or what should we do? Okay,
I think we can just hear.
Yeah.
I think the Ingalls approach where we were surveying the Wood Street corridor for residents' perspective on their needs and their wants, and how Ingalls could interact with them to accomplish the things that they wanted to change. I think that was a very significant step in the right direction. I think it not only allows the patient voice to be heard, and I think it needs to be heard at all levels. I think there need to be there, and we have patients at board meetings, you know, just to express their perception of the things that are being presented, and then we hopefully as CCPs involve patients in their medical decisions on a regular basis. But I think just understanding what the community is looking for and where they see deficits and where they see their strengths, I think that helps a lot. So just surveying and allowing that voice. And the other thing, well, I can.
Let's try to keep with this 1, 2, 3 for one more person, and then if it falls apart, we'll come right back to you. Are there systemic? Yeah, go ahead.
I think 2 examples of it. One, I think the clinical team does a lot about strength-based approaches. So I think one area we don't really do that as well is in the evaluation. Like, we don't ask questions about like what's going great in your life. What are the things that you have available to you that you know you really value? We're worried that you'd be at risk. So I do think we're kind of missing out on that in some sense in understanding what the opportunities are for the participants in our studies and intervention. One area where what you have becomes very important, in fact, is when we recruit people. Because they have to give up the doctor they have if they get the doctor we're offering them. And those conversations are often pretty detailed and rich. So we do have a little bit of that, but it's the exception. And it's only because we're kind of forced to confront it. And so I think there is a lot of opportunity to do more in understanding this, particularly from an evaluation perspective. I don't have enough insight to exactly how much of it we do in clinical settings, but I believe we try to do quite a lot.
And I think listening, being aware of what someone views as an asset can feel to us as a provider like a deficit or a barrier, right? I look in, the reason I can't go to a shelter, I can't move, et cetera, right? And this comes out of domestic violence in the world, right? But the reason I can't is that my mother's a shut-in and I look in on her every single morning and I make sure that she's clean and showered, et cetera. Who's going to do that for her? Oh, well, maybe we can send care. No. I do that because that's part of who I am. And that's the only thing I feel positive about, where I feel like I'm creating value. And I want that housing, but I'm worried about my mom and I'm worried about, I'm gonna create value. Man, not going to that other program is getting in the way of your addressing the very thing you came here to seek help for. Right? And so I think that just to complexify what David put on the table too, it's not just as simple as screening for these things, but it's actually understanding what column something like being housed or being unhoused or being in a certain relationship or not in a certain relationship falls in, and being aware of where the provider and the patient are on the same page and where we're on different pages. And maybe people should be introducing themselves.
I'm Mark. I'm actually with Lisa for a few years on medical partnership. I'm over at Loyola now. On that first point, you know, it makes me think a lot about social security facility. And when you talk about what you have, we are exceedingly constrained as attorneys in the system, where we are required, and cannot do a good job for our patients, we don't do this, to coach them in explaining what they cannot do. And this process can take anywhere from 7 months to 2 years to 5 years in some cases, where repeatedly they're filling out paperwork, you're talking to judges, talking to them about all the things that they cannot do. And there was an article that academic from Jens Ludwig wrote earlier this year, I think it was, about just the need to really reframe the whole concept of the social safety net to meet the needs that we have that we understand right now. And I think that calls for just a higher level of communication about how to act, what we should be, what questions we should be asking about extra benefits. That should not be based on this idea that we just have to imbue people with a sense of worthlessness.
Yes.
Which is what the system does. I think, you know, Chicago and County have started to talk about, basic income means tested, but not health tested. It's a big difference. And I think those are steps that we can continue to push for, which, you know, we're going to run up against cost, but just saying that message that, like, we are further psychologically disabling the people that we think are trapped. And that's a problem. I mean, right now, there's nothing we can do about that other than go to our leaders and say, this is not, you know, trying to.
You're talking about there was a discussion earlier this morning about population health. And what I hear you talking about is public policy that is keeping entire communities on the social service equivalent of life support. Completely unnecessarily, but because it serves some other purpose. And the patients know that. Yeah.
Joyce King, here in Chicago. So I was just gonna say from a clinical perspective, this comes up a lot when we're talking about someone who is having more difficulty managing at home on their own. Might be someone who's elderly, disabled, a lot of memory problems. People come into the hospital, maybe they're not taking medication, maybe they don't have enough home support. We have these discussions about looking into living, looking inside our facility, and it's a really hard conversation because they like where they are, they like their neighbors, they're happy with the community that they have, they're close by, maybe children don't come over very often, but are around. And I think that then they're looking at, you know, we're thinking about safety, they're thinking about their other values besides that. And I think that's a really hard conversation, right? Looking at what they have, what they need, and trying to find that's just that we manage and talk about a lot. I think that having that trust, that long-term relationship with your physician does help a little bit. The relationship with the team, the social workers, we've talked about maybe over time, the different options that are available. I think that helps, but it's not exactly enough at the end of the day. I think that the system really choices aren't always.
Should we move on? I mean, we're talking a little bit about all of these. But I'd like us to also push in this for where there's the extra work that you all have to put in order to fight all the forces that are keeping you from seeing the whole person, right? There's, you know, what also struck me about this is deeply operator dependent work, right? We can talk all we want about the model, But fundamentally, who the heck is doing this work matters, matters really, really, deeply. And so, so what are what's the extra work on an individual, on an institutional level? What are those end runs that you all are doing, or barriers you're coming up against that you want your colleagues to know about, that interfere or enable the true centering of who somebody is, which includes, but is not just how well their health is progressing. I'm gonna call on somebody else, David, first. Go ahead.
Listening to me, all of those types of things, but we're still persevering and it's such a simple question, which that's the point. You could get a sense of what that person really after, if you could go from that as opposed to providing ways to keep.
Yeah.
It's a good practice for the end of decisions. If you can feel more comfortable having discussions just routinely with our patients. So what are your priorities? What do you see as your strengths in yourself and in your environment? And what do you see as the obstacles to meeting what your joys would be? And I think those have always been difficult decisions for us because it's not really what we're trained in as physicians. We're trained in the diseases and how to address those. And yet we know that that's not the whole, I use the analogy of the elephant. I, as a primary care, take care of the elephant. I don't take care of the phone for the person. But I think it's excellent that you're now asking that as the first question. And if we make that a priority, I think the other thing is CCP scores really high in mental health perception of the patient. And that helps everything else. So I think it's good that we start to have those discussions routine.
David?
I'd like to pick up on what Joyce's example about housing and sort of tell a story that gets at something I think is relevant to my favorite Rick's project. When I was a resident in Boston, I had a patient who had a bad stroke, who lived in a second-story walk-up apartment, couldn't get out. And he actually had a pension, and when I explored with him why he lived there, the answer was that his pension, his disability payments, basically were the source of income for his family. And what mattered for him was being able to provide for his family, and that's why he lived in this place that really for him was like a good life. And I was a resident, had no experience in all of this sort of stuff, and it never really occurred to me to have a conversation with him or try to seek a conversation with someone with his family about how they could get their needs met in some other way when the time came that he might not be able to do that. And one of the things that's been interesting in the discussions about the roommates program is very, very commonly when people talk about their interest in it, they actually talk about sharing housing in some form. And because it's comfortable, they have trust and they want to help. And that is wonderful, and it also raises these complex problems of your interest versus others. But it reminds me that when you think about fields like family medicine, because we address the needs of family, we talk not about patients as individuals, but in this broader context. And I think that more we do like couples randomization, CCP. We try to think about that sort of thing, but the extent to which we really open our doors to treating the family is probably still less than it could be, for a whole variety of reasons. But it's just this discussion of sort of centering patients as full individuals really reminds that if what they tell you they care about is their family, for you to really serve them, you we've gotta figure out how that family's needs are gonna, whether or not.
And to realize that we all give things up for things that we care about, right? And so there probably are lots of us in the room that have skipped our own medical appointments to, or done something that may not have been great for our health, for our, because we wanted to fulfill an obligation for kids or for a partner or for a parent or for somebody else. And it's complicated when you're in a position that your focus and your mandate is essentially on an individual as the center of an ecosystem, and that person sees their responsibility really differently, which is human.
I'm gonna just state the obvious when I hear models, but that's actually seeing patients in their so that is the way that saying that we have a number of stories for hospital home level and seeing the whole. So you don't have to hear the story, but we're current hospital. So the Signify and thinking in these hospital home levels, and then David originally we had somebody who was from your home, and they were still been stolen. So so that's just another way to kind of make these models even more robust and to really learn about it.
So systems and incentives and right. So Robin, you alluded to this, right? Like some of this can be a hard sell. And we heard this morning about like how important frameworks are and the mental models that are operating, et cetera. But I could come into this room and have listened and say, why isn't everybody, patients and providers, signing up for this? You have the data, you have the testimonies, you have the et cetera, et cetera. Yes, there are barriers to change sort of on an individual level and on a psychological level. What needs to change in the system what needs to be changed systemically for this framework in its different manifestations, for that flywheel to actually catch, for it to move beyond the for just to become much more probable that someone is going to just inherently encounter this as the dominant model, not as an alternative that they can sign up for.
So, like, a lot of this discussion, I think, thinking about very good for developing methods. But to your question, stakeholders who have been measuring population is trying to prove it are very focused on utilization, reduce costs, even survival benefit. But sometimes reframing the lens of the stakeholder might be important. Maybe developing a validated measure of patient-supported outcomes developed from the patient perspective probably will be very useful in the future in helping enact policies and models of care that are important. We've done very small focus groups protocol kind of start to develop what are the costs of our initial small pilot study. We started shooting a little bit of what we do in our program. Once a month, we're going to be having shared group medical where we have multiple patients coming in at the same time, seen by multiple providers at the same time, but also incorporating social work and nursing education into a 2-hour visit to each of the patients. The initial intention was to help reduce loneliness with care models. So that's why I think it's important to reframe what we're trying to measure and put it in perspective. Who is the value stakeholder?
And if you were to develop that, you could get a nifty 2x2, and who doesn't like a nice 2x2, right? That would help you really get more information about where the patient reported outcomes and the kind of outcomes we've been hearing more about today actually overlap, and where the patient feels they're doing better, but the results don't show they're doing better. We've heard a little bit about that today, right? Or vice versa, where, which certainly is something that in my work, I've seen a lot. The system's like, it's great. And the person's like, I don't feel like it's been that helpful. It's been a lot of work, but it hasn't really changed with fundamental numbers. Are there systemic opportunities now? Like there are more collective crises going on right now, locally, nationally, internationally. And we are in, and everybody has a crisis hangover also from the last couple of years. And those are when we're wily and when we are, sometimes in that fog of uncertainty, you can try new things and push new things. Of course, you're also exhausted. You're also, just trying to keep the status quo. But are there policy opportunities or systemic opportunities or local opportunities that you all have been able to or interested in sort of exploiting to move this forward faster and better and more sustainably?
One is kind of like the crisis. That notion of I know what I want to do to improve this patient's care. And I think it's really hurting a lot of our patients drive to burn out whenever to this model. Really helps address some of the things I've seen from these care providers who are just passionate. The other is kind of inequities in health. That's the notion of diversity, equity, inclusion, also addressing the systemic isms we're talking about. This model to me is really a way to right some of the wrongs and be able to provide and create those opportunities for help that we've been missing. And I know at my institution I just moved to, it strikes me as just a very important issue for University of Wisconsin. And so through the lens of equity, I think this is something that I would use to kind of talk about this to try to find support, because I think this is ultimately the issue. Those two things are really important drivers.
Who else has a sharing or a question for our panelists who I'm going to in a minute, so you all can prepare. I'm going to give you guys the last 7 or 8 minutes to each offer a closing reflection or question you want the group to think about or challenge. Yeah.
Sharing on it from Denver Health, our safety. And I am an outpatient person trying to work more on the inpatient side, so I can bring here. And so from an organizational standpoint, above and beyond kind of the complex care that I do, our system is really trying to use kind of care and training, system training, starting with the executive board, going all the way down to the front lines, to try and reframe the way we look at the works that we do, vocabulary. And it's easier in some settings than in others, right? My patients are in every part of the system. They're in the emergency department too, they're in hospitals. And so going into those places, I think we lost a little bit of steam recently pandemic because this is burnout thing. But one of the things, just to what I just started, I got involved very early on with our Heroes Wonderful and so right we're going to be talking to you about mental health and now we do a lot of things beyond that. But to really say we need to take these principles and these concepts and we need to employ them every space we're in. When we're on stage, when we're off stage, we need to treat our interdisciplinary team, not just interdisciplinary team members with this incredible level of respect and compassion, but also
pushing one another and figuring out sort of how to balance those things, but to really be that kind of frame that we're going to use wherever we are. And I think that's one of the things that has helped us a little bit in our journey in trying to figure out how do we build a better mousetrap, because we're limited by all these things, that policy, fee for service, whatever you might say, being landlocked and not having all the other health systems in Denver, not wanting to take care of every patient, right? And so I think that we had to find some tools that helped us really do the reframing, and that was the piece that we turned to. And as I said, as a part of that, I got to be a part of helping build a true responder program for 24/7 line, where whoever you are, your residents, students, you can be contractor, employee, call in, we do groups every week. And I think one of the things we're trying to do is use those nurturing concepts and then say, these are the same types of concepts we need to.
Thank you. Yeah.
Definitely a structure which should be so his condition of education, but it's so many different literacy.
Alicia talked about the role of MLP as a sort of as a translator. But what was particularly interesting to me is that you rooted that in growing up in a bilingual family and sort of being rooted in that translation. And I think that also speaks to, there's a lot of evidence that where change comes from, when you're changing a field, it comes from the periphery. It comes from the boundary spanners. It comes from the people that have non-normative experiences that they figure out ways to bring into the work and to articulate in ways that can code shift. And so I'm going to hand it over to you all, but I want you all to think about those 5 things that you wrote down, and to what degree are you bringing those in, not just to connect with patients, but what particular skills, experience, perspectives do those give you that are non-normative in the institution, in the field that you're in, that you could use to chip away at some of the barriers to institutionalizing what you all are doing more. All right, rapid fire, 2 minutes each. And then, because we are standing between
So just final thoughts. Well, so yeah, I mean, I think, one of the key pieces of an advocate's role is, again, it is looking for those best arguments, those assets that your patient client can bring to, getting them to the outcome that they're looking for. And, one of the, really just like truly beneficial things about being in these multidisciplinary, interdisciplinary partnerships is that you have this diversity of perspective, this diversity of expertise that you can bring to bear on a really complicated, complex question. And so, I am consistently invigorated and rejuvenated in this work, and particularly in teaching this work to new advocates as they come along in this interdisciplinary environment with social work students, with medical students, with law students, so that they can learn how they learn from each other. So they can learn the mechanisms of social work, so they can learn the thought processes, problem solving skills from medical students. And so again, and those legal analytical skills from attorneys, But again, always centering that patient client, always understanding and looking at that patient client as a whole person, as the assets. Exactly as you were saying, some of the things that we might consider deficits are actually the driving force that is motivating those patients, those patient clients to action, to, you know, to remedy their situation. So yeah, I mean, I think that this is the key. This is the secret sauce to improving individual, community, and population health.
I'll talk loudly. I keep coming back to the question, like, why isn't everyone on? And I'm like, this is, we're preaching all to the choir, like all of us are doing this work. But I think that is a little naive, and what it ignores is like, this work requires at a fundamental level, humans sitting with other humans in distress. And like that distress, that is not comfortable at like a baseline for any of us. And then it's within a medical model, which does amazing things to cure people all the time and fix things. And it's at times can be quick and easy. And, you know, Ram and I, like Joyce, we have these conversations all the time. The work we do doesn't feel good every day. There's not like huge wins, but it's like incremental, and then you have to bump up against frustration and grief and loss in your own and the person sitting in the room with you. So like it kind of makes sense to why a lot of, like, besides the payer issues and the metrics we're using, it makes sense to me why most, if not a lot of people would want to do this work. And systems, you know, as Ali pointed out, like it takes 2 years to show any type of like revenue case, other, like, of course people aren't going to be like running to this. All that said, I'm a double down believer in like, this is where we need to go. But I think to get there, we need, you know, commitments and assumptions and support for teams and patients to continue to meet and talk about.
No, I'll talk also. I think what's resonated for me, I mean, certainly in the work in general and in these conversations, is the healing power of relationships, and relationships, I think, held in having the values that Nicole highlighted in her presentation, where there is real accountability. And I think, of course, more and more opportunities for addressing power dynamics, as thinking about the differences. And I appreciate Katya, you know, pointing out that we all are patients also. And there isn't this sort of high tower that's separate with all knowledge and solutions for the people who have the problems. And so I think continuing to shift that framework in relationships is critical. And, you know, to David's point, there's room to better center that and what individuals have already, particularly as we think about making the case for models like this in other settings. And I think there are real structural and policy barriers that get in the way of that and make it challenging to radically move forward in centering relationships in that way. And it means that we have to center things like hospitalization rates and reductions, which, yes, are a signal of, you know, maybe improved health, but also is the language that is spoken to get buy-in, particularly when you're thinking about institutions implementing things like this. So so my hope for the group is really, you know, continued persevering and protecting space for building relationships in healthcare, but I think moving beyond those walls also.
12:45 on the nose. All right.